Uh, Good evening, all. So this is the ISAR Global Journal Club. This is the first of our series where we are planning to focus on the Indian studies. So before we launch this, I would like to invite Dr. Amit Patki. Can I have his CV, please? Hello. Yeah. Uh, So Dr. Amit Patki actually doesn't require any introduction, but he's the medical director, Fertley Associates Mumbai, and consultant for Kahar Hinduja Surya Hospitals. But importantly, he's the president ISAR 2024-26, country representative for Aspire, governing council member of ICOG. He's been president of MOGS in 2014-15, many international publications, and he holds a patent as well. So without waiting for more time, we will just get on. I would like to introduce, request Dr. Patki to just inaugurate this particular series with his few words. That's all. Thank you.
A very good evening. And at the onset, I would like to congratulate our journal editorial board led by Mohan Kamath and ably assisted by Padma Rekha for so willingly to accept to do this ISAR Journal Club Live. I'm glad that Sujata brought this up in one of our meetings, and I think it was a need of the hour. Our JHRS is doing strong, is doing well, and we all know that it has just received the accreditations, and we will soon have an impact factor. We have large number of well researched, reviewed articles in our journal, and we have a large number of Indian uh, researchers and scientists who publish their work in worldwide journals. So I thought it was very nice that we should have this ISAR Global Journal live where we discuss interesting papers which have been published, and we invite the author also to participate in the question answer sessions. So I'm glad that you all have taken this forward, and I wish you all great success, and I'm sure it will be one of the things to look forward to every month. So thank you once again to JHRS and Sujata for being the convener, and I look forward to very interesting articles, controversial debating articles to be discussed on this journal live. Thank you very much.
Thank you, sir. That's very kind of you to give us that brief overview of what we are planning to do. So without wasting any time, I would probably start this session. Can I have my slides? Can I share them? Yeah. So are the slides visible? Yeah. Yes. Yeah. Okay. My slides are visible. Sorry.
Yes, sir.
Okay. Thank you.
It's
So,
visible.
yes, thank you. So this is the very interesting series that we have kind of getting started with, and I'd like to thank the whole ISAR team and Dr. Sujata and Dr. Amit Patki who've brought this idea, and we thought we will move this forward. So this is the first of the series, and obviously we are just learning through the whole process. So the whole idea is to focus on Indian studies in this series. We know that we have challenges in clinical research in this part of the world. So we know also that we have, one of the reasons is that there's very limited funding on these clinical research in this part of the world. Training is the other issue that we know needs a lot of work. Overall, our clinical research ecosystem is in nascent stage. So there are a lot of challenges. Amid these challenges, we have had people who have worked hard, and with all the challenges around, they have been able to come up with some good studies which have been published in international journals as well as national journals. So we thought we will each of these sessions, we will showcase these studies, probably discuss the science part of it, but also discuss the logistics and how the planning was done and what are the take-home messages, be it the science part of it or be the research methodology part of it, because this is a way probably we can share ideas and probably come up with larger studies, pool our strengths, and the whole ecosystem can build up from here. So that's the thought behind this series. So to start with, we selected a study which one of our lead authors is here, Dr. Chinta Parimala. So this study was actually published in Fertility Sterility in year 2020. So we picked up this study to start this particular series. The one of the reasons was, of course, that it was published in the top journal in our specialty of reproductive medicine. And to, of course, give you a background, that moment the study was accepted, the editorial board, in fact, wrote a commentary on it. So that was something that was very nice, because they recognized the work and they felt that it actually deserved a editorial commentary. But the other learning point on this was that it did face some rejections initially. So it didn't make it in human reproduction, where we thought it had a better chance. And but it got rejected in human reproduction, one more journal, and eventually we had to go to Fertility Sterility, which accepted it. So even good papers will face sometimes rejection, and that is something that we have to learn. Some of the peer reviewers might not agree, but sometimes other people might see merit in our work. So perseverance is important. That's one of the messages. This article also was included finally in the ASRM practice guideline on female infertility. So that was a very big point. This is the highlight of this study. And as we know that clinical research should be done in a manner that it influences clinical practice. That's the whole idea. Papers are not written just for filling up our CVs, or we end up saying we have got so many publications. The eventual thing is to help our patients and make their lives better, more healthier. That's the whole idea of clinical research. So this paper did make into the guideline, and it does influence clinical practice. Now, one thing we would like to share on this particular paper is, how do we actually go about doing these studies? So I have been a part of this team, so I know exactly that we had to actually do some homework. So there was groundwork done in terms of understanding a very different design. So all of us are clinicians and who are very much into intervention. We would like to have randomized trials, or we try this new intervention and so on. But our thought process is a little limited in that manner. We had to start looking beyond the usual. That is, there is a lot of scope for this design, that is diagnostic test accuracy, where you can come up with very good studies. So one of my take-home message here would definitely to look at different designs, because that will open up more areas for research, and simpler studies still will make it in good journals. We also, so we kind of got out of our comfort zone and went into a different design, which we were not very familiar with at that point. We attended a good diagnostic test accuracy workshop at that point. So that further built up our knowledge base. Now, whatever was gained even during this brainstorming was applied to plan the study. As I have already mentioned, the diagnostic test accuracy studies have a lot of scope, because there are so many questions that are unanswered in a day-to-day OPD clinic, which test to be done at what scenario and so on. So it's a good high point that we can start looking at these designs. And that is why there's the same thing that I have highlighted, is that there are so many clinically relevant questions that haven't been answered. So that is why this design was quite useful. The other challenge, of course, was that we had very limited funding opportunities, but the study design was very helpful in reducing the cost. Uh, of course, the medical colleges have some institutional funding, very minimal, but it is enough to carry out a postgraduate thesis or a postdoctoral thesis. So this was a part of a postdoctoral thesis, and that's why we had some institutional funding which could cater for minimal testing that was required in the study. So those were the challenges. And finally, what really helped in this particular study was that the way it was projected, it convinced the editorial that there is a clinical equipoise. This, of course, the author is going to highlight that why the study was launched. Was it convincing enough? When the editor reads the first few paragraphs, they should be convinced that this is worth pursuing. And there were very few studies in this particular topic. So importantly, as I said, many of the diagnostic studies and so on they were done in the previous century, in 80s and 90s and so on. So we still rely on those studies to plan our current day clinical practice. So that's where the novelty factor came in. It was a prospective design and methodologically sound. So those were the reasons why it made it into fertility sterility. So with those thoughts, I thought we will probably move on. So again, to highlight that this whole idea of this journal series is to focus on Indian studies and studies done by Indians across. They have been published in whichever journal. We would like the authors to highlight the challenges as well. It's not only the science, but the whole process of building up a study and publishing it. We definitely would like to discuss the scientific content and get some take-home messages for clinical researchers as well as the clinicians and our patients. With those thoughts, I think I will now probably stop sharing my slides and invite, can I have Dr. Parimala's CV, please? Yeah, I'll just, yeah, 1 second. I'll just introduce Dr. Parimala is the lead author. So she is currently working as assistant professor in Department of Reproductive Medicine and Surgery in CMC Vellore. She is postgraduate from Kaktiya Medical College, Telangana, and she did her postdoctoral fellowship in reproductive medicine in CMC Vellore. And at her age, she's had few publications already in international journals, including Human Reproduction Open as well. So I would like to invite Dr. Parimala. I'm stopping. Yeah, she can share her screen at this point.
Thank you, sir, for that introduction. Thank you, ISAR Journal Club, for inviting me to talk today. As sir has already introduced my study, sorry, my video is not visible. I hope I'm audible.
Yes, yes.
And you can see my slides, right?
Yes.
Okay. So I'll
only request you, ma'am. Can you please go on the slideshow mode?
Yeah.
Thank you.
So I'll be talking about my study. The title of the study is Revisiting the Role of Serum Progesterone as a Test of Ovulation in Humanic Subfertile Women. It's a prospective diagnostic accuracy study. This was conducted in the year 2020. So before going to the study, I would briefly like to brush upon diagnostic accuracy test, diagnostic test accuracy studies. So in research designs, basically we have different kinds of designs like experimental, descriptive, correlational, explanatory, observational, and then the diagnostic test accuracy studies. So what do we actually mean by this diagnostic test accuracy study? So the main objective of these diagnostic tests is to classify if a patient has a disease or he doesn't have a disease. So mainly there is an index test and there is a reference test or the gold standard test. The index test is ideally the test which you want to test for, whether against the background gold standard test. So the properties of these tests are mainly they should be quickly performed, they should be safe, they should be readily available, they should be accessible, they should be non-invasive, they should not be expensive, they should not be susceptible to external factors, and they should be standardized. And ideally, when you are checking an index test against a reference test, the interval between these two tests should be as short as possible. So what are the properties of a diagnostic test? There are two things which are very so the measures of validity are sensitivity, specificity, the predictive value, which includes the accuracy studies. This 2x2 table plays an important role. So if you see in this table, there is an index test and there is a gold standard test. So this gold standard test will help us in knowing how many are actually diseased. The positive indicates the disease positive.
Sorry, Parimala, the slides are not moving. Yeah. Yeah. Yeah.
So here in the index test, we have, so there is in the first column is A, B, C, D, if you see. So if the index test is positive and even the gold standard test is positive, it is a true positive, that is A. If the index test is positive and the gold standard test is negative, it is a false positive. Then similarly, if the index test is negative and the gold standard test is positive, it is a false negative. And then there is something called a true negative where both are in unison. So sensitivity is mainly the ability of the test to detect all those who have the disease. That is A by A plus C. So all those who have the disease, how many actually have the disease? So that is the sensitivity. And specificity is the ability of identifying those who are free of the disease. That is D by D plus D. So sensitivity and specificity are mainly prevalence independent. Then we have something called the positive predictive value and the negative predictive value. So PPV indicates the probability of having the disease given a positive result. That is, how many are true positive amongst all those who have tested positive. So this is A by AC, and negative predictive value is B by C plus. So those who do the negative predictive value indicates the probability of not having a disease amongst those who have tested negative for the disease.
Slides
So,
are not moving.
Yes, I think the predictive values are mainly prevalence dependent. So there is something called kappa test, which checks the correlation between the index test and the reference test. So there are certain values which indicates the agreement between these two tests. So with this, so before going into the problem, maybe we have done this population who have a history saying that they so what I spent during the test for ovulation.
Sorry, Parimala, I think the slides are not moving. We need to just probably, yeah.
Now, sir.
I think you need to move it further. Yeah. The pop-up has come after that. You want me to share from my side?
Now
Otherwise, yeah.
Yeah, sir, you can share from your side.
Can I take the share slides, please? Yeah. I'll just probably 1 second.
We cannot see Parimala also.
Yeah, there was some problem
sir,
with it.
my video, actually there is a problem with my video. But,
Acha. Okay.
I'll just manage this thing. Is it visible now? Yeah.
Yeah.
Okay, so you were here now? Yeah. Yeah.
The next slide.
Yeah. Yeah.
Yes, sir, the next slide. So these are the NICE recommendations regarding the test for ovulation. The NICE recommends mutual confirming ovulation even in women who say cycles. But not women who say they have regular cycles. So so there is a clinical equipoise as to whether we have to perform a test of ovulation in eumenoric women, and then if we have to perform which test. So object of this to estimate the prevalence of ovulatory cycles in eumenoric women and to compare the diagnostic test accuracy of a single well-timed ultrasound with the mid-luteal serum progesterone. In this comparison, we have taken the well-timed ultrasound as the index test and the progesterone as the reference test. And then also to check the reported history of regular cycles in identifying the ovulatory cycles. So for this, we have taken the serum progesterone and ultrasound as a reference test. Criteria included all women between 21 to 35 years of age who reported that they have regular menstrual cycles. Those who have a history of irregular cycles, women, hyperthyroid, hyperthyroidism, anything may cause irregular cycles. So, phase, the days ranging from 9 to 22 days for a 28 days cycle. And the serum progesterone test was ideally done 1 week prior to the expected menses, and the value cutoff which we have taken was more than 3 nanograms or 9.5 nanomoles. So the upside, sensitivity, specificity, positive predictive value, negative predictive value, like 2 traits. So here we have
I'll just take. These are the results now. Yeah.
I think we've lost her, no?
Yeah. I'll just take a. I think she's in the next this thing. I'll tell her to take over from my side only. Is that okay? 2 seconds.
Yeah.
Yeah. 1 second.
Because her voice was also not that clear.
Yeah.
Hello?
Yeah, Parimala.
Yes, yes, ma'am. So with this study, we have noted that the prevalence of the ovulatory cycle with serum progesterone as the reference test, it was 88.5%. With ultrasound, it was 97.6%. So if we go back to the 2x2 table, so our reference test was serum progesterone and ultrasound was our index test. So we have checked how many women were ovulatory with this serum progesterone and ultrasound and what was the discrepancy and all. So we saw that the sensitivity was almost 100%, the specificity was 20.8%, the positive predictive value was 90.6%, negative predictive value was 100%. So when we followed up these women, these 208 women, we noted that almost 11 women had a prolonged cycle, like 5.3% of these women had a prolonged cycle. They did not have a regular cycle. And then another 9 women actually conceived in the same cycle. And if we go by the history wise, only 197 women had regular cycles. The rest 5.3% did not have regular cycles. So those women who had regular cycles were 197 amongst the 208 women. So in these regular cycling women, again, we checked the ultrasound against the serum progesterone. And then we calculated the sensitivity and specificity. Again, the sensitivity was almost 100%. And positive predictive value and negative predictive value were 93.4 and 100%. So when we checked the agreement between these two tests, we found that the agreement was almost perfect. The kappa value was 0.81. And then we also checked the positive predictive value of those women who reported that they had regular cycles in identifying what was the actual positive predictive value for that self-reported history, taking serum progesterone and ultrasound as reference. So in that, we found that almost 88.5% was the PPV with serum progesterone and 97.6% was the PPV with ultrasound. So previously, there were certain studies done which checked the prevalence of anovulation in women who had regular cycles, and they found something close to 3.7%. This was a study by Malcolm et al. In 2003. And then there was another study by Lynch et al. Who have used various algorithms to check the prevalence of anovulation amongst eumenoric women. And they found a percentage close to 3 to 18.6%, which is more or less similar to our study. So to conclude, there was a high prevalence of ovulatory cycles in eumenoric subfertile women. So this raises an important question as to whether we have to do a regular ovulatory test for all those women who say they have regular cycles, because the reliability of a self-reported cycle was actually high in predicting the ovulatory cycles. And there was a perfect agreement with single well-timed ultrasound against serum progesterone, which would again say that maybe we can do a single well-timed ultrasound in identifying an ovulatory cycle rather than doing a serial folliculometry to identify the ovulatory cycles. So following this study, this was the recent fertility sterility ASRM practice committee opinion in 2021. So what they say is now that a thorough menstrual history may be all that is required, and the prevalence of ovulatory cycles based on a normal menstrual history in a non-hirsute woman is as high as 99.5%. And the additional tests of ovulation are not required to confirm ovulation, but it may be used to augment the fertility evaluation when the history is indeterminate. That means if they give a history, proper history that they have regular cycles, you don't have to chase the ovulatory tests in these women. Thank you.
Thank you, Parimala, for such a simplification of your talk and topic. One thing I want to know
Yes,
that what is the role? Do you think there is any role of LH kits? People use LH kits also. So do you think this study could have been compared with urinary LH kits also?
Yes, ma'am, we can do that also, but then already the study which I have quoted in the discussion, ma'am, the Lynch et al, they have done that urine LH kits also, but it is again a cumbersome procedure. Every day we have to call the patient, we ask them to do a test, and then we ask them whether it was a positive result or a negative result and all. So we felt because the lady is going to come anyway for an ultrasound for the infertility evaluation. So we just had to time that ultrasound visit with her menstrual, with her period of ovulation, or where we can see a corpus luteum or something. And so that was the main aim, basically, to check whether ultrasound frequent visits we can avoid, and whether to omit the serum progesterone also as a test of ovulation.
Yeah. So what you are trying to say is that serum progesterone is really not required, and I agree, because most of us are not doing serum progesterone. I hardly ever do serum progesterone to check for the ovulation. So so you mean to say that a good history is very, very important to predict ovulation, and even ultrasound, you really don't need to call the patients so often. If you time the ovulation study very well, then even you can use these findings for IUI. Do you think that for IUI also this will be helpful, that we will reduce, because working women coming every day for the ovulation study is not easy. So maybe then you can really time it properly, and visits will be less.
Yes, ma'am, we can consider that also. Then that should probably, maybe a single ultrasound may not help in timing the IUI, but yeah, maybe we can predict what time she may ovulate, and accordingly we can plan the IUI.
Any Sujata, do you have any
Yeah.
question?
Yeah, Asha, I wanted to ask some questions. So, Parimala, it was an excellent study.
Thank you.
What a simple, elegant, fabulous study, and there's so many things about the study that I did not know. But I have some methodological questions, if you can, if you can clarify.
Yes.
Number one is,
Yes, ma'am.
what exactly, because what exactly would you mean by a well-timed ultrasound? And
Yes.
you're written that it is varying from day 9 to day 22.
Day 22. Yes,
So
ma'am.
it means that out of your 208 patients,
Yes,
some patients were done at day 9, some patients were done at day 22, right? That's what you understand.
Yes.
And the second part of the same question is, how many sonologists were involved in this study who were doing the scans?
The sonologist involved was me only, ma'am. I only
one?
Yes, ma'am.
So that is excellent point.
Yeah, and because this day 9 to day 22, the range, ma'am, basically we were even tracking, even if she had a developing follicles, like few the lady whom we must have done an ultrasound on a day 9, we saw a developing follicle for her, and subsequently we did a serum progesterone, and we found that she actually had an ovulatory cycle. So that ultrasound, ideally we can do it even in the follicular phase, mid follicular phase, early follicular phase also, and it can range up till the luteal phase. Like in luteal phase, we can check for the corpus luteum. We don't have to exactly see a dominant follicle to say she is ovulating. Even if the follicle is 10 or 11 mm, and subsequently in the same cycle, if the serum progesterone was positive, we have taken it as an ovulatory cycle. So what I would like to say
means
is
that, sorry to interrupt, which means that every patient, let's say you've done a 9 or 10th day scan and you've seen a growing follicle.
Yes, ma'am.
So it is presumed that she would have ovulated.
Yes,
and then her ovulation status was confirmed by day 21 serum progesterone.
Yes.
But then how does that, as a clinician, if I do a scan on day 9 and I see a follicular dominant follicle, if I do not do a day 21 or progesterone or a scan at that time, I cannot confirm that she's had a ovulation, no?
Yes, ma'am. But that is what this study is mainly about. Like when we have seen amongst this 208 women, what we have noted is almost 197 of these women had regular cycles, whomever we have seen a developing follicle or a dominant follicle in the ultrasound. So you are saying if you have just seen a smaller follicle, whether it will actually go and rupture or not, that set of women whom we have done a scan in the early follicular phase would have been very few in our study. But maybe we have to see, ma'am, because there is always a component of luteinized unruptured follicle where the follicle may not have ruptured subsequently and all.
Yeah.
Yes, ma'am, that I can
So
understand.
the point
So,
is, my point of saying was that if we are comparing two things, either you do a single test for serum progesterone on day 21, or you do a single well-timed scan, which according to, let's say, a clinician, if the patient is sitting in front of me and he has reports a 28-day cycle, I will time that single ultrasound in the secondary phase, right?
yes,
That
yes,
one scan might give me a similar information. I thought this is what the study was, but then I didn't understand why you would do day
yes,
9.
ma'am.
That is why I asked.
Yes, ma'am, because we wanted to see, like, even if a developing follicle was seen, we have taken as that as one of the markers for ovulation, and then we subsequently did a serum progesterone, and we found that it was positive.
And then what would be all the various size? Sorry, one more minute. So what you would say are the various ultrasound features that you have taken? Number 1, growing follicle, and
Yes,
then number 2 are corpus luteum.
Yes, ma'am. These two,
Nothing
and then
to do
some women had a collapsed follicle with a free fluid in the POD.
that was also
is
taken as a
taken
sign of
sign of
ovulation.
ovulation. Yes.
Okay, it wasn't nothing to do with the endometrium. Only
No,
the
ma'am. Only the
ovary.
follicle, only the ovary. We
So these
didn't
three
check the
signs,
ovulation. Yes.
maybe
Yes.
increase in size of the follicle? No.
No, ma'am. We did only a single ultrasound. We didn't do a repeated ultrasound.
Yes, you are right. You are right. So these 3 ultrasound features. Okay.
Yeah, yes,
Thank you. Thank you.
Sure.
Parimala, what is your definition of eumenoric women?
That means a lady who says, I have regular cycles. If she
do you want to say that from a cycle of up to 24 to 34 days?
Yes, ma'am. So for our study, we have taken day 21 to 35 days as eumenoric, plus or minus 3 days. That is what we have taken as eumenoric, ma'am. If you see the article per se, in that we have defined what we have taken as eumenoric cycles, ma'am. According to the FIGO, we have taken, I think, 21 to 35 plus or minus 3 days we have taken as eumenoric.
And you excluded the women with PCO, and
Yes,
you excluded the women with diminished ovarian reserve also, or no?
No, ma'am. Diminished ovarian reserve we have not excluded. Only the PCO women we have excluded.
Parimala, a very good study, very basic, very simple. And I congratulate you because I think these are the studies which actually define lots of changes that can happen in our practice.
Yes, sir.
Because mid-cycle progesterone is by tradition taught as one of the tests that we should do. So what made you think about trying to see whether this was actually needed? What was the thought behind doing the study?
Yeah, basically the thought was that when a lady says she has regular cycles, is she ovulatory or not? That was the main idea behind that. And then we always wanted to see, because these are the regular tests which are done everywhere in the infertility practice. The serial ultrasound follicular monitoring and a serum progesterone test is a routinely done test to check the ovulatory cycle status. So we just wanted to compare these two tests and see whether which test is better and whether we can simplify the test process a little. So that was the main idea behind doing these things. Whether actually, if the lady says I have regular cycles, with what accuracy
What is
can
the
you say
proof of-
that?
yeah,
That you can say that she is actually ovulatory. Do you actually need to do all these tests, or just can you go ahead with the history itself? That was the main idea behind.
So I really congratulate you on doing something very basic, very simple, but actually having far-reaching consequences.
The
Thank you.
study question was actually Dr. Mohan Kamath, sir. He has actually conceived this idea, sir. The credit goes to him, actually, and he was my guide also during this study. I'll just call sir. I think sir is here only, ma'am. I'll just 1 minute.
Asha, there are some questions from the audience.
Yeah, those are some not related to the topic, but we can really discuss these questions. So maybe I will ask you this question, Sujata. One is till what age can you do the egg freezing?
What? These are the questions in this webinar.
Yeah. So I feel they are not really related to the
Yeah,
topic.
sorry. Then I think we should ignore it.
Yeah.
We can ignore it. Yeah. I didn't see the question. I just
Because
thought.
the questions are what tests are mandatory during stimulation and pickup? What is the dose?
No. We don't.
So this
we
is not
don't discuss
relevant to the topic. So I
Yeah,
think
yeah,
we discuss
absolutely.
more about research now.
Yeah. So Mohan, this was a fabulous study. And it's the kind of study when you see, then you feel, hey, Bhagwan, even we could have done this. and it had such a beautiful outcome.
Yeah.
And because ultimately we take for granted so many things, but science needs proof. So once you show in a study with a good number of patients, so that brings me to another question. So the power calculation for the study was 208 patients adequate for this kind of study?
Yeah, ma'am. So that is the thing. If it's a novel study, no. So power calculation in this was perfect, and the traditional rules of intervention studies don't apply here in the diagnostic accuracy. That's why in my initial thoughts I shared this is a different area, and we also learned a lot during the thing, because diagnostic test accuracy is not our usual thing. We don't do that. Even reading part we hardly do. People, even my postgraduates, keep saying sensitivity, specificity, and we have to be very specific on what we are talking when these parameters. So it was a learning for us. So, and it stood the scientific scrutiny. That is where it is. But the main, I think Dr. Parimala has shared this. What bothers us was that we still see a lot of clinicians using follicular monitoring for ladies. I found it very upsetting that why should ladies be subjected to repeated scans? We take it, gynecologists take them sometimes very lightly, but I found this quite challenging thing. I wanted to cut down this practice, calling scans repeatedly just to document key follicle is rupturing, which is simply not science. You just, and we were very careful of the wording. We didn't use ovulation. We said test for ovulatory cycle. So we just want to document it's an ovulatory cycle. We are not chasing the ovulation. So that was the thinking behind it. But it was satisfying to see that the people who actually wrote the editorial had done work on this ovulation, and they were convinced about it. So, and finally, the ASRM did take it up and use this quotation. So that is something that we are quite happy. But we were hoping that the UK groups, actually the NICE group, looks at it, because NICE still recommends ovulation 10s in a regularly menstruating women. So, but they of course didn't take it. Yeah.
Mohan, how difficult is it to get the ethical clearance for such study? Because it looks simple. So ethical clearance should
ethical is very
usually...
easy. So that's what, ma'am, basic thing is money was almost not required for this study, and ethics was not an issue, because we are not doing something really out of the practice. So that is why the whole we wanted to bring across to the audience that simple studies which are very meaningful for the patient will make it to the top, and you don't require money at some point. But of course these are not easy. You have to think about these ideas. But I just thought this platform to tell and bring in confidence to other people also, that even with less budget we can cover with big studies, big impact studies.
Yes, certainly. If anything, this study proves that. It attracted a editorial comment that was very big. I would have normally thought ki, like everybody knows, you can, ultrasound is as good as, like Asha started by saying, rarely ever, if ever, we do a serum progesterone, although we know that NICE guidelines and others, they keep saying that you need a progesterone to document. We never do it. But then you need people to show it that actually you don't need to do it.
Very good.
So I think we don't have too many questions, Asha. Maybe we can wind up. Next time you have to find us
a lot of sensitization towards scientific studies and all. But if we keep on doing such studies, that will appeal to people.
70 people have logged in. if
Yeah.
we don't count ourselves, 70 people have logged in, which is
Very
very
nice.
good.
That's very
Yeah.
good.
And also we probably didn't have too much time to propagate this amongst our medical colleges and all that, which we will do it for the next time.
Yes.
So
Great. So I think we can wind up the session now.
yeah. Fabulous.
Thank you,
Thank you so much.
Thank you, Mohan.
Yeah. Thank you.
Thank you, Mo.
Thank you.
so much.
Bye.
Bye. Bye.
Bye.